Yes, he has this problem after climbing 4 flights of stairs. Oh, yes, true. Iron deficiency does not cause lymphadenopathy. It can cause, he has not black stool, so it's not iron deficiency anemia. Mm. Is he is taking any sort of drugs? Uh, Sorry, he does not have any sort of disease, and there is only lymphadenopathy. You are thinking about bone marrow infiltration. Okay, after bone marrow infiltration, and nothing fits there. Yes. Okay. Then numerous cause of anemia. The numerous cause of anemia may be divided into three categories: decreased red blood cell production, decreased red blood cell production, bone marrow infiltration, increased RBC destruction, hemolysis, and blood loss. So, decreased RBC production, bone marrow infiltration, increased RBC destruction, hemolysis, and blood loss. The patient is the patient in the vignette has several signs and symptoms suggestive of lymphoproliferative disorder, most likely a lymphoma, including generalized lymphadenopathy, splenomegaly, constitutional symptom, fatigue. The anemia of lymphoproliferative disease such as leukemia and lymphoma is due to replacement of RBC progenitor cell with cancer in the bone marrow. Treatment of the malignancy may improve the patient's anemia, though many chemotherapeutic agents are myelosuppressive. So what he does he anemia of lymphoproliferative disease. The anemia of, yes, he may have lymphoma. Hypotension, tachycardia, tachypnea, fast. Con- i- is more and more fluid can cause metabolic alkalosis. Okay, it can cause coagulopathy. I don't know what am I thinking. Okay. This patient with penetrating abdominal trauma has signs of hemorrhagic shock, hypotension, tachycardia, and cool extremities, and likely ongoing hemorrhage. Fluid on Free intraperitoneal fluid on fast focused assessment with sonograph for trauma. Such patient once received early aggressive crystalloid resuscitation to restore intravascular volume and normal blood pressure. And balanced resuscitation, aka damage control resuscitation, is used. It includes the normal following measures: limiting use of crystalloid less than 1 liter, which dilute existing coagulation factor and platelets, and thereby increasing coagulopathy. Sorry. No, increasing coagulopathy means coagulation happens. That means the existing clotting factors are washed away, and that's why there is increased coagulopathy, like increased coagulation, like increased, uh, what can I say, increased clot formation. If you think in sorry, yeah, uh, these clotting factors are washed away from the from the tissue side, but it is accumulating in other areas, like uh, if this coagulation factor accumulates in the spleen and they start accumulating here, and if they starts accumulating in the hepatic vein or other areas, then it can causes coagulopathy. Maybe I am thinking in that way. Okay. Replacing the loss of intravascular volume replacing the loss of intravascular volume with blood product rather than crystalloid, transfuse into a ratio similar to 1:1:1, like platelet packed red cell 1, plasma 1, and platelet 1, and permitting hypotension. There is permissive hypotension to limit ongoing hemorrhage and prevent clot formation and rebleeding. With balanced resuscitation, blood products are administered with the balanced resuscitation. Blood products are administered only as needed to maintain blood pressure. If mean arterial pressure is more approximately 65 millimeter, sufficient for tissue perfusion until definitive hemorrhage control, surgical intervention can be achieved. In addition to coagulopathy, Aggressive crystalloid resuscitation has been associated with the following detrimental effects: hypothermia, room temperature. Room temperature fluids are cooler than body temperature and can cause hypothermia, which worsens coagulopathy, especially when administered in large volume. And acidosis, large volume of rapidly administered normal saline can cause non and hyperchloremic metabolic acidosis, okay, which can further worsen the performance of coagulation factor and increase mortality. Lethal triad, hypothermia, acidosis, and coagulopathy already present in severely injured trauma patient and increased risk of mortality. So if we give aggressive fluid resuscitation, in addition to coagulopathy, it can cause hypothermia, it can cause acidosis, it can increase the mortality. Okay, you got it? Okay, okay, yes, nitrofurantoin can cause G6PD deficiency. I am thinking from yesterday, like G6PD deficiency, nitrofurantoin, yes, it should be avoided, and other dapsone should be avoided. There are some other drugs. Okay, nitrofurantoin, yes, dapsone, primaquine. Okay, so it's a memorizing box. Okay, I'm reading the explanation. Medication that can you give me a minute? I'm coming. Okay, that was very easy using Discord. Okay, we can uh, we can communicate here up to May. Then we can go on that. Okay, okay. This hmm, okay, medication that often trigger hemolysis in G6PD deficiency. Well, we should avoid dapsone. We should avoid dapsone, isobutyl nitrite, nitrofurantoin, rasburicus, and primaquine, mm, and use with caution like acetaminophen, aspirin, chloramphenicol, chloroquine, colchicine, diphenhydramine, glyburide, isoniazid, L-dopa, quinine, sulfamethoxazole, trimethoprim, and vitamin K. Okay, this patient's dysuria, low abdominal pain. This patient's dysuria, low abdominal pain, urinary incontinence, urine analysis suggests a urinary tract infection for which antibiotic therapy is needed. However, she likely has G6PD deficiency given her prior hospitalization for hemolytic anemia with low baseline G6PD. G6PD deficiency is an inherited disorder associated with episodes of hemolysis during oxidative stress. In this patient, oxidative medications such as nitrofurantoin are particularly likely to trigger hemolysis and must be avoided. Other common oxidative triggers include infection, leukocytes release highly oxidative or highly oxidative reactive oxygen metabolites, and faba beans metabolized into highly oxidative compounds. G6PD deficiency is X-linked and primarily affects male patients. However, female patients who have homozygous mutation and skewed lionization or heterozygous mitigation overexpression of the erythrocyte with mutated X chromosome can also express the disorder. Okay. Calcium may be normal. Anemia, thrombocytopenia, and acute kidney injury. He has fever and neurological deficit. It's TTP. Yes, he has confusion and headache. It's TTP because fragmented red cell DIC-TTP has help. Fragmented cell, triangular cell, helmet cell. These type of cells are present. Sorry, why? Me, I don't know actually the answer. I know the I know the diagnosis. 8.4, we do not need blood transfusion. We do not need any sort of transfusion. No, it is either hemodialysis or plasma exchange. You are right. We need to clean the. Uh, it should be exchange or hemodialysis. It should be exchange. Okay. I look in the explanation we will found. Like look at the pentard. I am talking about this pentard for the last 2 days. Like this pentard. You need to differentiate between HAS and the TTP. Hemolytic uremic syndrome and TTP. In TTP, there is the word says the word tells everything. Like TTP is thrombotic, thrombocytopenic, and there is purpura. Okay, TTP is thrombotic, thrombocytopenic, and purpura. So in TTP there is thrombocytopenia and there is anemia. So anemia, thrombocytopenia, and acute renal injury like renal insufficiency, and this is for TTP. And if there is plus 2 factor like neurological changes and fever, so if these five symptoms all together, it's called Raynaud's pattern. You click the Gemini and write Raynaud's pattern, you will find the Raynaud's pattern. RAU, yes, pattern, yes. It's not Raynaud's phenomenon. No, not this. Raynaud pattern is another thing. You go downward. Raynaud's pattern for TTP. Look right on this. Yes. So TTP pattern is a thrombocytopenia, anemia, neurological deficit, renal problem, and there is fever. These five. So altogether, these five symptoms. However, most patients do not have all five manifestations at the time of the diagnosis, and cases are most common in previously healthy individuals in the middle age who are female and black, pregnant, or obese. Immune TTP is caused by autoantibodies. Immune TTP is caused by autoantibodies against the plasma protein Adam TS13. Adam TS13. Low Adam TS13 lead to accumulation of the long chain. Low Adam TS13 leads to accumulation of the long chain von Willebrand factor on the endothelial cell, platelet, which traps platelet and generates thrombi in areas of high shearing force, arterial capillaries. Patients with TTP will have MAHA schistocytes on peripheral blood smear. Coagulation factors are generally normal. In contrast to these with DIC coagulation, although purpura often occurs in the setting of severe thrombocytopenia, it is not always present in patients with TTP and is required for the diagnosis. TTP is life-threatening and must be treated with emergency plasma exchange, which removes the platelet plasma and replaces it with donor plasma. These replenishes Adam DS13 and remove the autoantibody without emergency packs like plasma exchange. Mortality is approximately 90%. So TTP is closely related to HAS because both MAHA and thrombocytopenia, both cause MAHA and thrombocytopenia. Unlike TTP, HAS is typically with E. coli 015787. Infection is primarily disorder of the renal system. Neurological findings and fever are uncommon. And in one thing I want to add, like in HAS, you should not give antibiotic. Yes. Yes, it's high. Normal. LDH, sorry. LDH is due to hemolysis. It's one signs of hemolysis. It can cause the cervical axillary lymph node to enlarge, but is it cause hemolysis? Is it the medication? Hydroxychloroquine does not cause bleeding, as far I remember. Yes, that's the thing. Maybe it's lymphoma. This patient with long-standing SLE has fatigue. A long-standing SLE with fatigue, low-grade fever, lymphadenopathy, fatigue, low-grade fever, and lymphadenopathy associated. This feature can be in the setting of acute SLE flare. Additional manifestation of disease, joint symptoms, rash, oral ulcer, serositis are usually present. Furthermore, patients with well-controlled SLE have significant weight loss and elevated LDH. Significant weight loss and elevated LDH, given the constellation of the finding, the most likely diagnosis is non-Hodgkin lymphoma. Patients with chronic autoimmune disease, SLE and Sjogren's are increased risk of non-Hodgkin lymphoma due to persistent B-cell stimulation, immune dysregulation, exposure to immunosuppressive agent hydroxychloroquine. Non-Hodgkin lymphoma patients with progressive painless lymphadenopathy and B symptoms, weight loss, fever, night sweat. Lab evaluation often revealed elevated LDH, likely due to tumor burden, liver involvement, and occasional hemolysis. Confirmation is usually made by excisional lymph node biopsy. Confirmation. Okay. Yes. Certain medication, phenytoin, can cause painless peripheral lymphadenopathy with or without signs of serum sickness, fever, rash, arthalgia. However, hydroxychloroquine does not typically cause these manifestations. G6PD cause by itself. These patients upper respiratory tract infection, rhinorrhea, cough, followed by followed by a few days later by hemolytic anemia. Hmm, Hemolytic anemia, dark urine, scleral icterus, back or abdominal pain, raises strong suspicion of G6PD deficiency. G6PD is an enzyme that generates NADPH, a cofactor required to make glutathione. Without glutathione, oxidative metabolite superoxide anion hydrogen peroxide accumulate in the erythrocyte and denature or precipitate hemoglobin into the Hinge body. Dark red erythrocyte inclusion. Dark red erythrocyte inclusion, which reduces the erythrocyte flexibility, lead to red cell damage and lysis of the reticuloendothelial system. Although G6PD deficiency is clinically silent at baseline, patient can develop episodes of hemolytic anemia following exposure to oxidative triggers such as infection, activated leukocyte release, reactive oxygen species, medication, trimethoprim, sulfamethoxazole, nitrofurantoin, or certain foods, fava beans. G6PD G6PD is X-linked and affects approximately 10% of the black women in the US. It is also commonly seen in those Mediterranean, Middle Eastern, and Asian descent. For yes, front, anterior, thymoma, teratoma, terrible lymphoma, teratoma. Yes. Okay. Look at the box first. In anterior, there is thymus and lymph node. Thymus, there is thymic neoplasm, thymoma, lymphoma, germ cell tumor like teratoma, seminoma, non-seminoma, and thyroid tissue, ectopic, substernal goiter, middle lymph node, pericardium, heart and great vessel, trachea, and main bronchi and esophagus. And the masses are lymphadenopathy, lymphoma, benign cystic mass, pericardial cyst, bronchogenic cyst, vascular masses, and esophageal tumor. Posterior, like neural tissue, vertebra, and lymph node. There may be neurogenic tumor, schwannoma, neurofibroma, meningocele, spinal masses, and lymphoma. Okay. This patient has vague chest discomfort, frequent upper respiratory tract infection, a middle mediastinal mass most likely has bronchogenic cyst. Mediastinal masses are categorized according to their location within the anterior, middle, and the posterior mediastinal compartment. Most sources define the middle component. Most sources define the middle component as the space between the anterior pericardium and the ventral surface of the thoracic spine. It contains heart and the great vessel, trachea, and main bronchoesophagus, pericardium, lymph node. Masses that arise from this structure may include the following: lymphoma or lymphadenopathy, with broad differential of the mediastinal lymphadenopathy that includes sarcoidosis, metastatic lung cancer, granulomatous infection. Benign cystic tumor include bronchogenic cysts, pericardial cyst, and enteric cyst. Vascular masses including aortic aneurysm and aortic arch abnormality. Esophageal tumor including large esophageal cancer with extraesophageal invasion. Bronchogenic cysts, the common type of benign cystic tumor, typically arise from anomalous budding of the foregut during congenital development of the tracheobronchial tube. In infancy or adulthood, affected patients may become symptomatic with chest discomfort and non-specific respiratory symptoms such as recurrent coughing, frequent respiratory infections. CT scan of the chest with IV contrast can be usually be confirmed the diagnosis. Okay, just look at the last line and before that hematology. Yes, there is only one diagnosis. Yes, so you can save your time in this type of question. Okay, this infant has jaundice, hemolytic anemia, and elevated MCHC consistent with hereditary spherocytosis. Hereditary spherocytosis is due to inherited defect in the RBC membrane proteins spectin and chirin, which results in fragile sphere-shaped RBC that becomes trapped and hemolyzed in the spleen. A newborn with hereditary spherocytosis often have hyperbilirubinemia that requires phototherapy. Although physiologic jaundice is expected, although physiologic jaundice is expected in the first week of life due to increased RBC turnover, shorter fetal RBC lifespan, and decreased bilirubin clearance. Severe or prolonged neonatal jaundice more than 1 week raises raises suspicion for inherited hemolytic anemia. Reticulocytosis on blood work confirmed the hemolysis and elevated MCHC. Reflex spherocytosis due to membrane loss and RBC dehydration. Other lab findings include low to normal MCHC, low to normal MCB, negative direct Coombs test, and spherocytes on peripheral smear. Treatment is primarily supportive. RBC or exchange transfusion may be considered for infants with severe hemolysis. Next, yes, G6PD, yes, maybe. This patient developed hemolytic anemia, low hemoglobin reticulocytosis, and icterus after taking dapsone, likely indicating likely indicating underlying G6PD deficiency. In this condition, erythrocytes are unable to generate sufficient NADPH to counter oxidative injury, superoxide anions from certain medication, dapsone, trimethoprim, sulfamethoxazole, primaquine, an infection or foods fababin. This results in period of hemolytic anemia, whereby lysed erythrocyte release heme into the circulation. Lysed erythrocyte release heme into the circulation, leading to hyperbilirubinemia and hemoglobinuria. Hyperbilirubinemia heme is catabolized to bilirubin. Heme is catabolized to bilirubin, which causes scleral icterus and jaundice. And hemoglobinuria, heme is excreted in the kidneys. Heme is excreted in the kidneys, which causes dark colored urine and a false positive urine dipstick for blood. False positive urine dipstick for blood. The heme in the hemoglobin causes positive urine dipstick test, but no erythrocytes are seen on urine microscopy. Diamond black fun. Okay. Uh, Diamond black fun anemia or pathogenesis is congenital erythroid aplasia. There may be craniofacial abnormalities, triphalangeal thumb, and increased risk of malignancy. Norm lab findings: macrocytic anemia, reticulocytopenia, and normal platelet and WBC. Treatment is corticosteroid and red cell transfusion. This patient has macrocytic anemia, craniofacial anomalies, and triphalangeal thumb consistent with diamond blackfan anemia. DBA is caused by a congenital defect of the erythroid progenitor cell, which leads to increased apoptosis of the red blood cell, resulting in profound anemia. Most patients have anomalies such as short stature, cleft palate, and webbed neck. Diamond blackfan anemia typically presents in infancy with progressive pallor and poor feeding due to anemia. As seen in this patient, the heart rate increases to meet oxygen demand, and faint systolic ejection murmur may be heard on examination due to increased turbulence across the valves. Lab testing differentiate the type of the anemia in contrast to Fanconi's anemia, pancytopenia, bone marrow failure. DBA is a pure red cell aplasia with reticulocytopenia and a normal platelet with blood cell count. Treatment mainly involves corticosteroid or transfusion therapy in the refractory cases. Okay. Is it anti-D or splenectomy? Is it anti-D or splenectomy? Platelet transfusion, if you give, it's ITP, idiopathic thrombocytopenic purpura, you don't know the cause. So if you give platelet, again your immune system will kill the platelet. It is immune and idiopathic, all are same. It is the name. Immune thrombocytopenia is an autoimmune disorder in which IgG antibody against the platelet, IgG antibody against platelet membrane protein, resulting in isolated thrombocytopenia. Most cases of ITP self-resolve within 3 months. However, some patients continue to have platelets less than 1 lakh for a year, which is known as chronic ITP. Adolescents with mild initial presentation and no preceding viral trigger are most likely to develop chronic ITP. Chronic ITP evaluation includes bone marrow examination and blood tests for infection, HIV, hepatitis C, cytomegalovirus, and autoimmune disorder like SLE, thyroid disease. Evaluation is if lab evaluation is negative, management is similar to acute ITP. This includes observation if this includes observation alone if asymptomatic or in combination with glucocorticoid, anti-D immunoglobulin if Rh positive and Coombs negative, and IVIG for bleeding episodes. This patient has bleeding thrombocytopenia and repeated pharmacological intervention and should be considered for second line therapy rituximab, TPO receptor antagonist or splenectomy, not uh, although not without risk of sepsis and thrombosis. Splenectomy removes the source of the platelet destruction and is often curative in patients with ITP. Okay, yes. Anti-D immunoglobulin is potential first-line therapy for ITP in patients with Rh antigen. Anti-D anti-D binding to Rh positive erythrocyte. Anti-D binds with the Rh positive erythrocyte is thought to saturate the Fc receptor of to saturate the Fc receptor on the macrophage within the reticuloendothelial system, therefore thereby limiting the ability of the reticuloendothelial system to clear platelet. This patient is Rh negative. Okay, sorry. Immune thrombocytopenia, there is platelet autoantibodies preceding viral infection, petechiae ecchymosis, mucosal bleeding, epistaxis, and hematuria. There may be isolated thrombocytopenia, few platelets size normal to large or on peripheral smear. Children observe if cutaneous symptoms only, and glucocorticoids, IVIG, or anti-D if bleeding. Adults observation if cutaneous symptoms and platelet more than 30,000 and glucocorticoid IVIG or anti-D bleeding or platelet less than 30,000. Okay, next. Oh, no. So maybe hemoglobin defect. You are talking about hemoglobin defect. It's not red cell membrane defect. It is hereditary spherocytosis or PNH. EPO will be CKD. I think that you are in the right track, like thalassemia, maybe hemoglobin defect. Okay, the most common cause of microcytic anemia, iron deficiency anemia, and thalassemia minor have similar lab, low MCV, low MCHC, and peripheral blood smear, target cell hypochromia. Differentiation requires iron studies, but empiric iron supplementation is sometimes prescribed, and lack of improvement in hemoglobin levels within 4 weeks. Lack of improvement in hemoglobin levels within 4 weeks makes IDA unlikely. Therefore, this patient has likely thalassemia genetic disorder with hemoglobin defect. Hemoglobin A, the major form of hemoglobin A, the major form of hemoglobin, and hemoglobin in children and adult contains 2 alpha globulin and 2 beta globulin. Transcription of 4 alpha globulin Transmission of 4 alpha globulin and 2 beta globulin genes tightly regulated plus specific ratio alpha or beta globin gene production. In thalassemia, mutations or deletions more than one gene alter the ratio of alpha or beta globin synthesis. Precipitation of excess unpaired globin chains results in erythrocyte toxicity in the bone marrow and ineffective hematopoiesis. Okay. Yes, circulating antibodies of erythrocyte membrane and circulating antibodies of the erythrocyte membrane and traumatic hemolysis, erythrocyte shearing on artificial heart valves can cause hemolytic anemia, usually associated with normocytic anemia and sometimes manifestation of hyperbilirubinemia. And erythropoietin promotes erythrocyte differentiation and maturation most likely most likely seen in renal failure and is associated with normocytic anemia. Okay. Is it upper extremity DVD? Um, Prominent superficial veins are present over the proximal right arm and shoulder also. So looks like other does not fit. I do not know actually the answer. Yes, there is no muscle breakdown. There is not. There is erythema, acute pain, heaviness. Okay, risk factor is central venous catheter, repetitive arm motion like baseball pitching, weightlifting, and malignancy. Weightlifting and malignancy. Manifestation acute arm edema, heaviness, pain, and erythema, dilated subcutaneous collateral veins in the chest and upper extremity, and pulmonary embolism. Duplex or Doppler ultrasonography, 3 months of anticoagulation, thrombolysis, non-catheter related. This patient, this young patient with acute pain, heaviness, swelling, and erythema of the right arm likely has upper extremity DVT, although most upper extremity DVT arise in the setting of central catheter, peripherally inserted into central catheter. Otherwise, healthy patients can occasionally develop spontaneous DVT due to thoracic outlet abnormalities that compresses or injure the axillosubclavian vein. Young athletic men are at high risk. Most cases are linked to hypertrophy of the scalene or subclavius muscle from weightlifting or damage to the vein from repetitive overhead arm motion, baseball throwing, of the congenital abnormalities of the thorax, cervical rib can occasionally lead to spontaneous DVT. Manifestation tend to arise in the dominant arm within hours of strenuous activity. Pitching a baseball game, patients usually have generalized acute swelling, heaviness, pain in the upper extremity. The pain often improves with rest, elevation of the arm to the level of the heart, as in this patient, and elevation above the head typically worsen symptoms. Nearby superficial veins, proximal arm, shoulder may become dilated and collateral, as collaterals that allow bypass the venous obstruction. Urschel sign. The diagnosis is generally made with Doppler or duplex ultrasonography. Yes, cellulitis, often extremely treated with cephalexin or soft tissue injury infection, which MRI can help to diagnose and can cause arm pain, erythema, swelling. However, these patients diffuse arm swelling and prominent superficial vein, coupled with an onset of immediately following repetitive overhead movement, are most concerning for DVT. Upper extremity venous ultrasonography should be performed. Upper extremity venous ultrasonography should be performed first in this patient. Performed first in this patient. And rest, eyes, compression, and elevation. Rest, eye, compression, and elevation are typically recommended in the treatment of medial epicondylitis, golfer's elbow, which sometimes occurs in pitchers. Although medial epicondylitis often results in arm pain, the pain is localized to the medial elbow. It would not cause edema or erythema of the entire arm. Acute exertional compartmental syndrome. Acute exertional compartment syndrome associated with elevated CK level due to muscle breakdown and can occur after strenuous physical activity. However, associated pain is typically excruciating and Other neurologic finding, paresthesia, weakness are often present. In addition, the diagnosis is made clinically, in some cases aided by compartment pressure management and not by measuring the CK level. It's not like inadequate iron doses, because normocytic normochromic anemia, and it is new to iron locked up anemia of chronic disease like option E, and impaired EPO production like CKD. It is not the answer. It is in between A and B. Normocytic normochromic anemia looks like mm, autoimmune hemolytic anemia. Uh, like impaired EPO production. Maybe. Mm, okay, it's impaired EPO production. Okay, I don't. Okay, it's anemia of the prematurity. Okay, anemia of the prematurity, increased oxygenation at birth, increased oxygenation at birth, decreased EPO production, and impaired transition from hepatic to renal typically occurs in the third trimester. So typically renal EPO production starts at the third trimester. So impaired transition for hepatic to renal EPO. Exacerbating factor in premature infants: decreased RBC lifespan, frequent blood draws, and iron depletion, often asymptomatic poor weight gain, apnea, hypoxia, normocytic normochromic anemia, and inadequate reticulocyte count response. Management is RBC transfusion. If severe or symptomatic, minimize exacerbating factor like iron supplementation, limit blood draws. This patient has normocytic normochromic anemia with a minimal reticulocyte count response, which indicates that the bone marrow is not producing adequate red blood cell to compensate for anemia. The most likely cause in this 7-week-old preterm infant is anemia of prematurity. After birth, increased oxygenation, breathing, ductus closure trigger reduced erythropoietin production by the liver and kidney. Low levels of circulating EPO impair erythropoiesis in the bone marrow, which normally causes a mild transient anemia that reaches a nadir of around 9 to 11 at age 2 to 3 months in infant. Physiologic anemia of the infancy compared to preterm infants have lower initial hematocrit at birth and a shorter erythrocyte lifespan and less capacity to produce renal EPO. Therefore, their erythrocyte tends to be more severe. A 7 gram per dl occurs earlier 1 to 2 months, resulting in anemia of the prematurity. Frequent phlebotomy in the neonatal intensive care unit can further exacerbate the condition. Many cases of anemia of prematurity are asymptomatic. However, mild tachycardia is common, and a flow murmur apnea, poor weight gain can also occur. Lab evaluation: normocytic normochromic anemia with normal platelet leukocytes, although the absolute reticulocyte count may be normal for age. Reticulocytosis in response to anemia is absent, as seen in this patient. Okay, next. Do you want? Have you done your breakfast? Okay. Okay, then. Sorry. Okay, we can take a break.